I am Dr. M.S. Reddy. I am a psychiatrist practicing at Asha Hospital. I am the director of this Asha Neuromodulation clinic. My basic interest is in the mood disorders, specific interest in bipolar disorders. So the last one and a half decade, I am running a clinic, Asha Bipolar Clinic, with a predominant focus on bipolar disorders. Let's talk something about the mood disorders. And before that, maybe I'll say one of the reasons why this specific focus on neuromodulation. When we talk about neuromodulation, very specifically about transcranial magnetic stimulation, and to be a little bit more specific, Deep TMS, Deep Transcranial Magnetic Stimulation. This is the treatment which we offer at ANC. ANC, we have a few centers. This is our major main center. Maybe you can call it as a hub at Gachibowli. And we have centers in Dilshik Nagar, we have in Vizag, Vijayawada, Mysore, Bangalore. But predominantly when we talk about neuromodulation, TMS, what is it? TMS here, transcranial magnetic stimulation, we offer treatment for depression, what we call as major depressive disorder, and OCD, Obsessive Compulsive Disorders. As on today, these are the two main psychiatric conditions we are offering our treatment. There are a lot of other indications, let me focus on this. Straight away, one question is that, right, any psychiatric disorder, let's talk about depression. There is medicines, you give medicines, you do counselling or CBT, whatever name you give it. What is the requirement for the third one, this neuromodulation? There are two ways. One is that there are some people who do not respond only to medication. Some people who do not respond to medication plus counselling. This can be a third, or maybe as on today it's augmenting, maybe later can be alternative. So this is a third mode of treatment for the management of depression and an OCD. One is medicines, second is counselling or CBT, whatever name you give it. Third is that Deep TMS. One of the goals here is that, which is a very very close to my heart, is can we show the patients an improvement? I may not talk about recovery there, a significant improvement as early as possible. Today, if you ask me as a psychiatrist, as a doctor, when a patient with depression comes into my clinic, even though I talk about very good prognosis, you're going to recover, you're going to improve, complete recovery is possible, then standard dialogue is that it may take about 3 weeks or 4 weeks. Give me about 4-5 weeks. Is there something which I can do so that whether I can show the response within about a week? Of course, there is another treatment which is generally what is people talk about, shock treatment and ECT. In some patients, it does show very rapid improvement, but we don't give it all the patients. So here, one of my pet ideas is that compared to what it was, let's say about half a century back, there is a phenomenal progress in the pharmacotherapy of psychiatric disorders, especially depression. At some point of time, we had medicines, but they had a lot of side effects. But today we have medicines, what we generally call as SSRIs, selective serotonin reuptake inhibitors. I think they have done a great job. And if you ask me, I've been in psychiatry for the last 40 years, 4 decades. The drug fluoxetine, which Prozac outside, I think all of you would have heard about the name Prozac. Here we have different names, there are a lot of brand names, which has come in 1980s, precisely I think 83, 84. As a psychiatrist with 4 decades of experience, if you ask me, the drug fluoxetine, which is branded as a Prozac, is a game changer in the management of depression. It has done a huge service to psychiatry, pharmacotherapy of psychiatry. It made the treatment of depression is so easier, manageable as an outpatient. This is a drug which has shown a very promising reports without much of side effects. I am sure now millions of patients who are otherwise suffering with depression but had a lot of problems with the previous medication called tricyclics, switched out to this, they are being benefited by this drug very much. This is one of the game changers, if you ask me, in the medication treatment of psychiatric disorders. Yes, 80s it has come, but for the last 4 decades, nothing really beyond that. Nothing really beyond fluoxetine, escitalopram. These drugs do work excellent in some patients, but all of them we have to wait for 3 weeks or 4 weeks. or 5 weeks or 6 weeks? Is there any possibility that we can do shortening of this? Can I show the response? Can I get my patient out of depression in about a week or 10 days? Right now, maybe, but generally I don't think I can talk about it. In that kind of situation, whether TMS is going to be of some help, this deep TMS is going to be some, it is showing to be of some help in some patients, but I cannot definitely say that, but their results are very, very promising. It's a very safe treatment, deep TMS is, and that's why we can give it the medicines and counseling. That is the purpose of starting Asha Neuromodulation clinics, which I talked about. And I'll go back to depression. Major depressive disorder we talk about. If you look at the mood disorders broadly, there are 4 different types. One is a major depressive disorder where it's only depression. Second is a premenstrual depressive disorder, PMDD. It's related to the, like a lot of people talk about premenstrual tension. Third is DMDD, disruptive mood dysregulation disorder. And lastly, the most serious of all this is supposed to be bipolar disorder. Major depressive disorder is a depression. This is depression. Significant group of patients with major depressive disorder. Disorder is not because of family issues, stress, worry, tensions and all that. Predominantly it's a biological, neurochemical disturbances in the brain, neurobiological disturbances in the brain. What exactly the chemical? It may be serotonin, norepinephrine, dopamine, but it's predominantly because of neurochemical disturbances in the brain. But how do you explain that? How do you talk about it? A lot of times we talk about MDD, it's a depression, the feeling of sadness and depression without any context. It's like this, I fail in the exam, I get depressed. I lose something in business, I get depressed. There are some serious issues, I get depressed. But a lot of times, quite a few patients present to us without any of these problems. They ask, there's nothing doctor, I was alright. But suddenly last 1 week I have been feeling that something is not going right, which is correct. Depression, sadness, inferiority feelings, negative thoughts, suicidal ideation, feeling low, feeling dull, feeling in blues, not sleeping, not eating, disturbance in the mood, not showing interest in anything. All these things can come as one group of symptoms without any reason. Yes, it is without any reason. These are the patients who do very well with your treatment. Here let me tell you, I did talk about premenstrual tension, premenstrual depressive disorder. This sometimes I call it as, this is obviously you know that it's exclusively in females. And then at this point let me tell you, if you look at the depressions, it's twice more common in women compared to men. Twice more common. For every one man who has got depression, there are 2 ladies who have got depression. This PMDD purely related to the menstrual periods. It's a peculiar phenomenon. Just 2-3 days before period starting, they'll start having this significant mood symptoms. They don't feel good, they feel uneasy, they feel irritated, they feel sad, and then small things now they get irritated and they snap at it. They don't know why it's happening, but they know impending the another 2 days, the time when the menstrual cycle is starting. Once the cycle starts, the second, third day, they become completely ordered. It's like a magic. The rest of the 20 days, they are all right. Absolutely no problems. But then again, the next time the period starts, 2-3 days before, they have these symptoms coming up. Once the period starts, it's going up. What exactly is this? This is what this PMDD, premenstrual depressive disorder, is what I call, in my personal opinion, these are micro major depressive disorders, micro episodes, brief episodes, short episodes. Almost all the time they disappear, but these 4 days they can give a terrible problems to the lady. Now like suddenly the family members start looking at what's happening, why is she behaving like that? She was not like that few days before. This also gives me a feeling that there is something in the female hormonal systems which is contributing to the development of depressive disorder. If someday we can unravel what exactly is the hormonal upheaval which is happening pre or during or post-menstrual period during that 1 week, if we can unravel clearly one after the other systematically, that may throw a lot of light on why people develop major depressive disorder. At present it's not happening, but someday I am hopeful that this may be the gateway. Trying to find out why a woman develops PMDD can be a gateway, unraveling the hormonal disturbances to know that why some people develop major depressive disorder. As I told you about depression, it's most of the times without context. No reason, but I get depressed. We see a lot of patients like that. Some of you may not believe it. You probe further, you will get some no. Patients are very clear. Patients are very intelligent people. Doctor, nothing happened. I feel like that. Doctor, 2 years back, exactly like this, doctor, it happened. 5 years back, doctor, it happened. This is what we call as a recurrent depressive disorder. 5 years back, I had this for about 2 months or 3 months. I became all right, doctor. I got treatment. Then it disappeared, doctor. Again, 2 years back, I got doctor for 2-3 months. I became all right, doctor. But now again, I'm having that. So this is what we call as a recurrent depressive disorder, which is largely because of brain neurobiological changes. We have some clue about what exactly is happening, but nothing definite about it. But an advantage here is that, suppose a patient walks into my clinic, let's say about 35-year-old man or woman walks into my clinic and says that, Doctor, 2015 I had my first depression which lasted for about 2 months and I became alright. Then again 2018 I had, doctor, another depression and I became alright. 22 I had another depression and for 3-4 months I became alright. Now again I am going to through this. This is the patient where I am going to tell them that, yes, right, the diagnosis is recurrent depressive disorder, but don't worry, you will be alright. Doctor, am I really going to become alright? Because depression, there are a lot of negative cognition. This is one patient where my diagnosis is recurrent depressive disorder. I am going to tell them that you have to become alright, you will be alright. Give me about 3-4 weeks time, 4-5 weeks time. Whether I give medicines, whether I do counseling, whether I do some other treatment, you are going to become alright, ma. Doctor, can you promise? Yes, this is not my arrogance. This is the nature of the illness. This is the confidence I have in the current medication treatment, what we have, and then counseling. You're going to become all right. See, look at this. If this can be conveyed to the patient, how much of a positive feeling it can generate? Because depressions are they pull them down to the dumps. They think of nothing is going to happen. This is what is the advantage of making a correct diagnosis. And this is what, once again, say that these are mood disorders. Mood disorders are good prognosis. When I say good prognosis, a significant number of patients, whether we talk about major depressive disorder or PMDD anyway, it's always a good prognosis only for 4-5 days and they become all right. Bipolar disorders, they're good prognosis. Episodes may come again and again, but each episode is completely they recover. Recover they completely. That's an advantage. Provided you identify them early, treatment correctly, pharmacotherapy, supportive reassurance, take the family into confidence. Family must be taken into confidence and they should be getting the positive feeling that you are going to become all right. Give us some time. So what if you don't treat, what happens, doctor? You're telling that anyway they are going to recover a spontaneous natural course also. Here we have to understand the risk of suicide is 15% in these people. A lot of times what we see in the newspapers and then what we read then could be, there may be a lot of anecdotal things which should have been described like that, okay, there's a failure here, there's a problem here, there's something here. It could be an underlying depression that could be the reason the person has committed suicide, attempted suicide. If you can treat depressions correctly, promptly, completely, there's a good chance that, I don't say that we can completely prevent suicide, significant number of patients or persons, we can get them out of these suicidal feelings and then suicidal thoughts. So that is where the depressive disorder, mood disorder, a lot of patients, it's a good prognosis, they recover. You need to see what best we can do, how short period we can get them out of it. Medicines, TMS, reassurance, and see that suicides are prevented. Doctor, how is it possible that you can get them, why are you thinking about getting them a faster response? What's the problem if it is 3 weeks or 4 weeks? See, the medicine as a whole in the last few decades is changing. When I was a student, if somebody has a myocardial infarction, heart attack, general warning is that rest, complete bed rest. For the next 3 weeks, don't move. Don't even get up except to the washroom, you are not going to move. Complete restriction of your. Today somebody gets an MI, tomorrow morning they are going to get the stent done, and third day, even after the bypass operation, third day they say to get out of the bed, start walking, go back to your work as soon as possible, cardio rehabilitation. So the kind of a morbidity, the quality of life which was such a severely restricting when somebody has a heart attack, any major surgery it used to be, don't move, you're not going to be, it can give you problems like that. Coming out of it, see, imagine a patient with a heart attack goes get a stent done or graft done. Fourth day, he is out of bed, out of hospital, into the community. But maybe you need to take some rest. But the kind of freedom the patient has. It may be my dream, whether it comes to bipolar disorders or other mood disorders. Can we replicate a similar kind of a faster response, speedier response in psychiatry also, at least in some mood disorders, at least in depression, at least in mania? Can I do it? How soon can I do it? How fast can I do it? That's where my focus is completely going to be. Start the treatment promptly. See that the patient recovers as early as possible and maintain him in that recovered state for as much time as possible. This is going to be the goals. Otherwise, suicide is going to be one of the biggest problems. Now, if we talk about bipolar disorder, briefly I'll touch on this. Bipolar disorder is nothing but what I talked about, depression plus mania. There's a combination. You have depression plus also manias. Mania is nothing but completely opposite of depression. Depression is sad, dull, keeps crying, feelings of inferiority, negative things, nothing interests him. He lost interest in everything, he doesn't feel like doing anything, life is worthless, I'll better rather go and commit suicide at the end of my life. Mania is opposite. He's very confident, he wants to work a lot and he doesn't want to sleep a long time. Sleep is a waste of time. I have this plan for next year, I have this plan for that. It's all in the happy-go-lucky and then like grandiose and then everything. But it's unrealistic grandiosity. It's not a realistic thing. We have to be optimistic. But this unrealistic optimism which takes them into a different sphere, and then that's where they can sometimes get into rash behavior. Expenditure can be very rash, sexual overtures can be very, very rash, over activity can be too much and then they can get into quarrels, fights and then it can be disruptive. This again has to be diagnosed promptly. Mania patient has to recover. 95 to 99% of the patients. Rarely we see chronic mania continuing. I almost say that 90% of the times mania has to recover. Manic episode has to recover. It recovers in 3-4 weeks, but can I make it in 1 week? Can I make it in 10 days? This is one of the goals which we have to look at in psychiatry. How soon, how fast? Get him out of the symptoms, get him back to the community, get him back to the reasonably decent level of work. So bipolar disorder is again. Here when we talk about bipolar disorder, I think nowadays people are Googling so much about the mood disorders. Nowadays patients are walking into my room saying that, doctor, I have mood swings, I think I have bipolar disorder. No, please no. Normal, we have mood swings. Mood swings are very normal. Everybody's cough is not a carcinoma or tuberculosis. Cough is cough, simple cough, irritant cough. The mood swings are normal. Every mood swing is not a bipolar disorder. So don't diagnose yourself. Bipolar disorder is a major serious problem. It has to be diagnosed by a qualified and a professional. So don't overdiagnose, don't get unnecessarily worried about having mood swings being bipolar disorder. That's important. So these are about mood disorders. Let me say a few words about obsessive compulsive disorder. This is another fascinating disorder. In the sense, very sad. In my opinion, as somebody who is in practice of psychiatry for the last 3-4 decades, if anybody asks me, which is the most severe, in the sense, the patient, which is the condition in psychiatry where the patient suffers the most. Severe condition may be bipolar and schizophrenia, but the condition where the patient suffers the most, it is OCD, obsessive compulsive disorder. What's the difference? In schizophrenia and bipolar, patient is not aware that I am having an illness. He thinks that he is alright. It's the relatives and the family and society suffers. OCD, obsessions, repetitive thoughts, compulsions, repetitive actions, washing 100 times, 1000 times. Let's take the example of washing. Here the patient is otherwise intelligent, brilliant, absolutely normal person. But when he starts washing, he has to wash 10 times, 20 times, 100 times. 3 into 10, 30, 30 into 10, 3, 90, 90 into 3, 270. It's a kind of a thing. Patient knows, is aware, is intelligent enough to know that this washing is not required. It's unnecessary, it's not required. People think that he's crazy. He suffered, but he can't stop it. If he stops it, there's going to be a tremendous anxiety building up inside him. So here, I know that I don't have to, but I want. I keep on doing. I know that I've locked the door, but I have to go and check it whether I locked the door 10 times. One of the funniest things is that I switch off the light. Obviously, when you switch off the light, it will be dark. But then I want to check it whether I really switched off the switch, and then I keep doing it. Ridiculous, silly. Patients think that everybody around that thinks that you're doing something nonsense. They are aware of it, but they can't stop it. So that's where a tremendous suffering goes through. These patients suffer. And then the range of symptoms like obsessive thoughts, now like compulsions, washing, checking, doing it again and again. In the road, and when you cross the door, you go 2 steps forward and then 4 steps backward. Blasphemy, the kind of thoughts which you get about your, during the time of prayers, and then very disturbing sexual thoughts about all. The plethora, the canvas of obsessive compulsive symptoms are so very wide ranging. I was just talked after 40 years, recently one of the young girls, at this point let me tell you, unfortunately most of the psychiatric disorders, long-standing disorders start in the second decade. I talked about depression, I talked about bipolar disorder, I talked about OCD. They all start in the second decade. That means the age of onset is between 10 to 20 years. Imagine a child around the age of 13, 14 going into depression. Imagine a child around the age of 13, 14 going on washing the hands again and again and again and again. Checking this thing and again, how much of time he spent on that. He's not able to study because his focus is on this, and his classmates are making fun of him. But unfortunately, that's the period it starts. That is why we have to be much more careful, identify it very early, treat it very early, so that these children, they'll get so disturbed. Sometimes the easiest method is that self-medication, they get into drug abuses and they get into a lot of problems with the other friends and colleagues and all that, and the parents, it's a problem. So you need to identify that very early. That's a very important thing. One of the children, when they came to me, she's just about now 11-year-old girl, she tells me, every time she washes the hands, she washes it 11 times. I didn't understand. Now why this 11? Because my age is 11. I was surprised. And like 11 my age, that's why I have to wash 11 times. So this is a kind of a repetition, is OCD, Obsessive Compulsive Disorder. Starts around age of 13, 14. Quite a lot of people, it's a milder symptom, they get away, but some people it's very crippling. I give an example. Suppose I'm a student preparing for my exam. I start reading from the page 1. Suppose half the way, this is what happens. I started reading, half the way some friend calls or something happens, again I have to start from the first sentence, first letter. Again I have to start. Suppose he spends his half an hour of time and only in one page, and then look at the kind of distress they go through because he has to study the whole thing, he cannot complete that. So this repetition, I have to wash my hands 100 times every time I wash. How much of time? I have to take bath for 2.5 hours. How much of time I am losing in this? Rest of all the work is pending, and then I do function, but functioning is gradually reducing to more and more minimal basic things. That is why we need to check it and do it. Doctor, how do the medicines? Yes, medicines work very good in this. I'm not saying that somebody who washes 200 times is going to come to 1. No, 200 times from that, I can make it 100. I can make it 50. I can make it 40. This is something which we can do. That's one thing which medicines can do, plus your exposure and response prevention, what we do. Behavioral therapy techniques, and then TMS is, like Deep TMS is one of the interventions where it's working very good. This is how does the medicines work? Medicines cut down the repetitions internally, neurobiologically. At this point, let me also tell you sometimes these medicines we do give when there is subjective disturbance. How do the medicines help? A lot of people ask me, I have some issues at home. There is some loss. See, a simple example, they say that, doctor, I had a business loss of about 10 lakhs. I'm depressed now. I come to you. You give me the medicines. You tell me, don't worry. I give the medicine. How does the medicine work? Yes, medicines works. What I tell them is that medicine cannot compensate for your 10 lakhs. But because you lost something, the last few days you have been thinking about the same thing again and again. 100 times, 200 times, 300 times you have been thinking about it. When I give the medicines, that can cut down the ruminations from 100 to 50, 50 to 20. So the pain of ruminations, the continuous talking about it, thinking about it gets reduced neurobiologically. My medicines work so that it comes to the minimum of 10 times a day instead of 2,000 times a day. The second thing is, the more and more you think about it, and your time is spent on this negative thinking, that you can't plan for the next business venture, you can't plan for the next exam, how do I study? So again you are going to fail. So my medicines do not help you pass the exam or make you pass, but it helps you to reduce the ruminating part of it and gives you that free time so that you can think positively about the business or the work or whatever it is to think about it. That's what my medicines can do. Same thing, sometimes these medicines work in some personalities. Like sometimes you see that in certain personalities, when there is an argument, I should have the last word. I keep on talking about it. The medicine sometimes, it's okay, reduces that rumination. Repeated talking, it's okay. Medicine sometimes make you feel it's okay. Let me not continue on that. That itself gives some kind of relief. Sometimes you wonder, obsessive compulsive personality disorder. Maybe, in my opinion, this is one personality disorder where this particular drug, SSRIs, do work very good. Because they cut down the number of times people keep on thinking about it. That's where it's an advantageous thing. So, broadly looking at that, we did discuss about depression, we did discuss about bipolar disorder, we did discuss about obsessive compulsive disorder. The reason why I selected these 2-3 topics is that one is that Asha Neuromodulation Clinic, this is what offers treatment for a reasonably quicker relief for depression and then OCD. And I gave you the thing that what medicines can do for these two conditions. It's a remarkable and phenomenal advancement in the pharmacotherapy in the last 3-4 decades. Hopefully, TMS can be one of those remarkably advancements in the management of these disorders possible. But what I tell is that when you get depressed, try to visit the doctor early and try to take the treatment completely, because quite a significant number, there's a good possibility that the patients do recover. I repeat, they come out of depression completely. They come out of mania completely. There can be a next episode which can be after 5 years, 10 years. But this present episode, they come out completely. You can go back to work, you can go back to college, you can study, you can continue the business, you can take care of the work very efficiently. But maybe I won't be able to comment the same with OCD, but substantial reduction can be there. I can't talk about recovery in OCD, but substantial reduction of symptoms is possible. So, looking at these psychiatric disorders, there's a phenomenal change in the last half a century. The last 2-3 decades, there's much more advancements. Medicines have become more friendly, less side effects, not much of a sedation. People can take the medicines and they continue to work. We look at symptomatic recovery as a realistic possibility. We are trying to see to best extent how we can make the functional recovery is also a possibility. And the most important thing is how soon, how fast I can get back the patient to get back to his work. How soon I can get back. The same example as I gave, surgery is done. He's not on the bed for 3 weeks as it used to be about 2-3 decades back. Surgery done, day after tomorrow he is discharged, goes for rehab and goes back to work. The same way, if I can, this may be my dream, but if we can replicate this kind of findings, if we can show this kind of findings in psychiatric disorders, especially it's going to do great help in the mental health of not of the individual but of the society. But the morbidity of mental health is phenomenal. That can help. That will give a very positive feeling for all those patients suffering from this kind of disorders. Thank you very much. Thank you.